I'm Sabine as your host today, and I'd like to welcome two very special guests and great friends of mine, Dr. Omar Saleh from Saleh Medical Radiology right here in SoCal, and Dr. Srini Tummala from Florida Vascular Specialists in South Florida. Welcome, guys.
Thanks, Sabine. Appreciate it.
Thanks for having me.
Glad to be here, guys.
Yeah, I'm happy to have you guys. I mean, today we're gonna delve into this world of atherectomy. Some people think it's a very controversial procedure, and some people think it's near standard of care. So we really want to get all sorts of perspectives. And so, yeah, I'd like to kind of have our listeners get to know more about your guys' background and your practices. Let's start with you, Srini.
Sure. I mean, I've been doing this about 20 years now. I started off originally in a standard private practice, group with the diagnostic radiologists and interventional radiologists. And then after about, 15 years, I was in a university setting as their director of limb salvage. And then now I'm part of Florida Vascular Specialists, which is really a primary outpatient vascular practice here in South Florida. So I kind of have a lot of different hats I've worn over the years. So
yeah, you've got all perspectives right there. That's great.
Yeah.
What about you, Omar?
I've been out for like 10 years. And I think for like the first 3 to 4 years, I was in a traditional diagnostic IR private practice, serving a few hospitals and doing mostly inpatient type of IR. Then I broke off and did my own thing where I was doing night radiology with your group, Sabine. Then started and kind of got
how
into
we know each other. Yeah.
Yeah. And got into the OBL side of things, like getting to the outpatient vascular or like other interventional procedures in the outpatient setting. And then I kind of started just doing my own thing as a solo IR, where I do mostly, I would say 95% OBL ASC, and then maybe 5% hospital and diagnostic work. And I've been doing that for like the last 2 years.
Great. Well, that's awesome. So, especially with something with atherectomy, it's really nice to have perspectives from all sorts of practices. Mine is a hospital-based private practice. And so I think from all three of us, we can really delve into this topic and kind of get into the nitty-gritty. So, most of our listeners probably know what atherectomy is, but Omar, can you kind of just remind everyone or explain what exactly is atherectomy?
So atherectomy is a procedure that's designed to remove plaque or thrombus from the artery. And then there's all these different types of atherectomy, which we can kind of get into, where it's rotational, orbital, laser, excisional, directional. So, and I have experience with like a few of those. I don't use all these different types of devices, but that's basically what you're trying to do is debulk the lesion in the artery, where it's, or modify the plaque where you get a better result, in terms of, luminal gain.
What do you mean by like modifying the plaque? I mean, there's debulking, which you're taking out the plaque.
Right. For example, like if you think of like CSI orbital atherectomy, you're using like a diamond crown to kind of oscillate and kind of it sands the calcium, the intimal and the medial calcium, where it kind of cracks it, I guess, in the sense where when you do a balloon angioplasty, you can dilate the artery in a better sense where you don't have to crank it up to such a high atmosphere, such a high pressure, where you get better result and like maybe less recoil.
Got it.
Yeah.
Srini, Omar mentioned different types. What are the different types of atherectomy we generally talk about?
Yeah, I mean, I think if you think of atherectomy in general, the idea is vessel prep, right? The idea is to try to return a diseased blood vessel, in this case, an artery, to a more normal compliance. You obviously never get to, 100% of normal, but the idea is to get it closer. You're obviously trying to get luminal gain as well, so that, like Omar was saying, you can achieve really an optimized lumen with really low pressure angioplasty, which then obviously we know from data reduces your chance for dissection, perforation, and just overall stent usage, right? When you think of atherectomy in terms of the four main types, there's obviously, like Omar said, orbital. So that's the classic CSI or Diamondback. Rotational, Jetstream, the Rotoblader kind of come to mind. Phoenix is the other one that, classic rotational atherectomy. Obviously there's ablative, which is laser. And then finally there's directional, right? And directional is kind of the Hawk, Silverhawk, Hawk One, Turbohawk, those types of, brand name devices basically. And, with directional, you can have it, image guided, non-image guided. The Avenger Pantheris is a image guided atherectomy. So that's kind of how I think of atherectomy in terms of big categories and what I'm trying to achieve.
I always have trouble. What's the difference between rotational and orbital?
Yeah. So, orbital obviously think of it as the crown itself is rotating in an orbit, like around a planet. So it's within the vessel rotating in an orbit versus rotational. Think of it more like a drill bit, right? It's drilling through whatever you're trying to treat. So that's the kind of the way I conceptualize or visualize it,
Yeah. So, okay, that's a great kind of, intro as far as different types. As far as, and this is a loaded question, Omar, in your practice, what is kind of your overall indication for atherectomy? Is it something that you're always going to do, or is there something, in the angiogram or something that makes you want to do it? What are some of your indications?
I do use atherectomy a lot, but I make my decision based on the angiogram, and I usually do a lot of intravascular ultrasound, IVUS, right?
Okay.
So what we'll do is we'll do the angiogram, and if we see a blocked artery, if we'll try to cross it and then if we can pass an IVUS through, then we'll kind of see what's going on. And, within the lumen, if it's like a lot of thrombus or non-calcified plaque, things like that, I probably will use, or calcium. I'll use an atherectomy device to kind of help, treat it. Because I think I've done both. I've done just angioplasty and stent alone and atherectomy, and I've gotten better results with the atherectomy. So my indication, is pretty, we will use a lot of atherectomy if we see some, really bad stenosis or disease on the angiogram or IVUS.
Yeah. You said something pretty interesting and about, stenting and stuff a lot of times if you look up atherectomy, if you look up a lot of papers, they'll say one of the indications is if you're trying to not stent. Is that something now, Srini, that you are you trying to do atherectomy to avoid stenting, or is it actually kind of like Omar said that you get a better result post stenting? What would you?
I think that's where part of the controversy is, right? Is atherectomy really indicated, right? There are many that believe that there's no good data to give you an absolute indication that says you have to do atherectomy. Obviously, that's where you have kind of two camps. And then there are those that believe that, yeah, we should do atherectomy. I think what Omar says is spot on. I think IVUS helps direct kind of atherectomy choice, or whether you're going to do it or not. In most cases, in my opinion, I guess that's my opinion, obviously. And I think, IVUS helping in terms of plaque composition. Do you have soft plaque, calcified plaque? Is it mild, moderate, severe? Do you have thrombus? Those are all the kind of things that will help kind of direct you towards what type of atherectomy you're going to use, I think, in many cases. Regarding the no stent zone, obviously most people classically think of the popliteal artery, especially behind the knee joint, below the knee, so the P2, P3 segments. And in general, the popliteal artery as a whole as a no stent zone. In other words, with all the forces from twisting, bending, and so forth, and rotation, you kind of want to avoid stenting. And so some people make the argument that, look, that's where vessel prep is the most important. And we really should be doing really good optimized atherectomy in those areas. Again, you can argue about what type of atherectomy, but they'll say we should do some type of atherectomy for good vessel prep so that we don't have to stent. And I think if you look at all the data on atherectomy, one thing is clear is you definitely have a lower bailout stent rate compared to when you don't do it. Whether it helps you for primary patency, TLR, amputation-free survival, limb salvage, and, future outcomes, that really hasn't been borne out, I think, definitively at this point.
Got it. And I mean, you've mentioned this a couple of times, and I think maybe I was going to save it for later, but like, where does the data lay for atherectomy? I mean, that's probably the first question people ask when they try to debate atherectomy. What data is out there to support it or to not support it?
Yeah, I mean, I think part of the problem is that, with atherectomy, you don't have any really good randomized control trials, right? You don't have good RCTs. You have retrospective analyses, prospective studies. You've got some registries, as in the Liberty 360, which shows you, in a lot of these studies, which show you that there's in terms of feasibility and safety, they're quite good. But in terms of all the other things, does it really make a difference in terms of outcomes? I think that's the one thing where both camps are always having a debate and a discussion. I think where we do have RCTs is in ISR, right? I mean, technically with ISR, laser atherectomy with Excite, has been shown. But again, the numbers weren't huge. So, again, that's where the debate comes into. So I think one thing we need is, and we don't have head-to-head comparisons between a lot of these devices. Is orbital better than rotational, better than laser, better than directional? We don't know. So I think the data is where we really need to kind of improve on at this point.
Yeah. Well, Omar, there's lots of different devices out there. You mentioned a couple of them. I think Srini mentioned a couple too. If in your practice, do you have all of them available or do you have a couple?
In my practice, we use mainly Phoenix, Rotarex, and CSI. And everyone has their own reason to use their device. For me personally, we use a lot of IVUS, so we have an incentive to kind of get the Phoenix catheters as in like a bundle package or things like that. So in the OBL, you're always trying to figure out how to get certain devices at a cheap price, and you want something that's safe and that works. So for us, Phoenix was a really good choice in terms of ease of use, usability, and safety. It has a pretty low embolization rate. Rotarex was a great. So in the OBL, I was encountering a lot of ISR, where we didn't have laser available to us at the time. So I was using Jetstream back in the day, and that's like a 7 French sheath, and you'd need like a filter wire and things like that. Yeah. So when Rotarex came, that was a game changer for us. So in sense, it's like a lower profile 6 French, but I use it a lot for ISR. And then for CSI, I usually use like the micro crown and treat the really calcified arteries below the knee. So that's kind of the main 3 that I use in my personal practice.
Yeah. Yeah. I would say, in our practice, again, it's Rotarex and CSI. That's really, our practice is kind of centered around those. Srini, what about you?
Yeah, I mean, I think that's a good model. I mean, obviously, we can't have everything, right? And sometimes when you have all of them, you start there's a confusion that happens in terms of, well, when do I use these? What's my protocol? What's my algorithm? And so, I kind of agree 100%. I think below the knee, I think orbital atherectomy works real well. I think it's a great device for that. I think the other one to have, you got to be able to treat ISR like Omar said. And I think Rotarex makes good sense, especially their larger catheters have some level of aspiration, right? And then laser is good too, whether it's the Philips laser or the angiodynamics laser. Obviously, the larger catheters on the angio D laser had some aspiration ability as well. So for us, it's been laser, above knee, and CSI or orbital atherectomy below the knee. I think, if you can't get laser, I like the BD Rotarex device as well. Full disclosure, I'm not a consultant. I have no financial interest in BD at all. And so I think that's another good device. But, again, you talk to different operators, and Omar knows this well. You talk to different people and they'll tell you, no, I like to use this device because it's the best device for this. I like to use this the best. I think, again, we don't have any data. And so I think it's very difficult to say one's better than the other.
Yeah. I think that's the problem a lot with endovascular. There's so many tools sometimes to do. I mean, I remember I struggled when I just started with doing peripheral vascular disease, and people are telling me I use this wire, that wire, this wire, that wire. This wire is the best, right? And then you get a little confused as to what to do. So with anything, what I've always done is just stick with, something and learn it well, and learn how the feeling is. So like how Omar and you mentioned Rotarex, you guys have had really good, results. You keep on using it. You learn the different, peculiarities of that laser. I don't use it that often. So now I don't know all the peculiarities and all of that. I think CSI, I always tell people who ask me what's the one, if you need one, type of atherectomy, you should definitely I think you need CSI in those calcified tibials a lot. I feel like that's been a great bailout use too.
One thing we should add, Sabine, and which I haven't mentioned, is it's not something that's really listed as an atherectomy device, but it's a vessel prep device, Shockwave, right?
Yep.
Shockwave, intravascular lithotripsy. I mean, the problem is it gets paid in the hospital, it gets paid in the ASC, but you can't get reimbursed in the OBL at this point. And so that's the difficulty in the outpatient, space that Omar is in, for a long time now, and what I'm getting into at this point and part of. So
yeah,
another
and
one.
Now Shockwave is not atherectomy, right? Omar, it like you mentioned, atherectomy is debulking. I mean, we did talk about plaque modification. It's really solely plaque modification. Is that right?
Right. Plaque, yeah. Deep. You're talking about atherectomy, right?
Shockwave. Yeah.
Shockwave.
Like
yeah.
intravascular. Yeah.
Shockwave. Yeah.
Intravascular lithotripsy. Yeah. I don't have that much experience with Shockwave. Like I said, I don't do that much work in the hospital. I have it. I do have it in the OBL. And I've used it a couple of times on like common femoral artery stenosis and things like that.
Sure.
And like some of these sick patients. But it's but yeah, it's great. It does work, but the mechanism is different, right? Like you're using like sound waves to like
Sure. Totally. Yeah.
like I don't know what integrate the calcium.
We'll go into it. I mean, we'll stick with atherectomy right now and touch on that. But what about, and this feel free to say whatever you want. I mean, any atherectomy you don't recommend, you've had a bad experience with. If you don't have any or don't want to share, that's fine. Anything, Srini, that you have to say?
I wouldn't say I've had a bad experience. I think it's like you said originally, Sabine, you get used to certain devices and the comfort level in terms of how they feel, kind of the pros and cons, you understand what issues there are in terms of using them, in terms of, getting them through lesions, advancing them through sheaths, different sizes, and things like that. And so I haven't really had a bad experience. I think I've found some of them a little more cumbersome than others.
Sure.
But then again, you talk to people who use only that device and they're like, oh, this is the greatest thing on earth. And I've had no problem at all. So I can't say I've had any really big problems with any of them at this point. I mean, I'd love to hear what Omar has to say.
Yeah, Omar, anything you have?
Yeah, sure. I have like a love and hate relationship with CSI. Like, it's awesome. It's awesome when it works, but then, like you're below the knee, you do a very delicate spin, and then next thing you know, you have like no flow going down to your foot, right? And then you're spending the next 2 hours with like a, tiny catheters, pumping adenosine and stuff, and doing aspiration, thrombectomy and stuff into these small little branch vessels. So for me, I make sure I kind of learned this, and maybe other people don't have this type of experience, but what I do is if there's not a good outflow in the foot, I may not want to use CSI that aggressively, or I have a wire all the way down in the foot. So if I do use CSI and there's some issue with the flow, I can take a catheter all the way down to the pedal arteries and just aspirate whatever trash is there. And then it usually works really well. But, that may not be as forgiving if you're in like some perineal branch where they have those little tiny branches that are going to the ankle that could be supplying the patient's, pedal artery. So that's one of those things I've learned with CSI. In terms of Rotarex, which I also use a lot, I would not recommend it like a calcified vessel so much, because sometimes you'll feel it. You're trying to track it, and you may feel some resistance, but it could lead to like a perforation. I think Rotarex is really good for ISR and a lot like thrombus or like a lot of non-calcified plaque morphology, things like that. That's kind of been my experience, and this is all anecdotal,
Yeah.
But I've been doing.
I mean, Omar brings. Oh, sorry. Go ahead, Omar. Sorry about that.
That's it. Yeah, that's all I was going to say. Yeah, go ahead.
Omar brings up a good point, Sabine. I mean, we really haven't talked about, when do you use which device when and when you shouldn't, right?
Mm-hmm.
And, with diabetes and CKD now, and, you guys all see this, we're seeing tons of SAD, right? Small artery disease below the ankle, where they just don't have a lot of runoff. And so I think a lot of these devices, you have to be careful when the runoff is poor. When you're talking about single vessel runoffs or no runoff, you got to start thinking to yourself, okay, should I use atherectomy? If I do use it, what's the problem I'm going to be dealing with? Because all of these devices, they all embolize, right? It might be a small percentage of the time, but they do embolize. And, one of the biggest things you got to worry about is that, because that can really take a case that may take, a half an hour and now all of a sudden make it a 3-hour case. And the other problem too is some of these devices don't work well in calcium and others do. So you kind of have to understand that distinction is this, and I think that's where IVUS, like Omar said, helps you tremendously. Am I dealing with predominantly soft plaque where I want to use these types of devices? Am I dealing with just heavy calcification where I want to use these? Or do I have a combination and then have thrombus on top of it? Well, that's going to also direct you into a different device. So I think what Omar brought up is a really key point and really important for people trying to learn atherectomy.
Yeah, it's a huge teaching point. It's exactly what I live by. If I have like a single vessel runoff, and then that runoff, whether it's the DP peters out or you've got tiny distal plantars, and you just know that if you knock out like a little tiny, 50 micron particle goes there, it's going to shut down everything. We've all had that water hammer effect post, intervention, and that basically is like your heartbeat just falling, like bradycardia, fall down.
Yeah.
So I agree. My practice, unfortunately, I don't do as much atherectomy as we probably should. Part of that has to do with the day is really busy and it adds some time, which we'll talk about. That's not necessarily the right thing to do, but one of the things I always think about is, okay, if this person has a nice runoff and I can do it, then I'll do it. And so it's something that's a very good teaching point for all our listeners.
BD understands that anything that can help to save time, space, and reduce complexity in the lab is essential. The Rotarex atherectomy system is simple to set up and easy to use, with a small plug-and-play capital component and reusable handle that is easily draped. In a healthcare environment where costs matter, all device-related accessories are in each catheter set at no additional charge, including the Rotarex guidewire. This device is not for use in cardiopulmonary, coronary, cerebral, iliac, renal, or venous vasculature. To learn more, visit bd.com/Rotarex. Click the link in the podcast notes for instructions for use for indications, contraindications, hazards, warnings, and precautions.
One question I had, and some people comment, like with directional atherectomy, where you actually are truly debulking a plaque, you're cutting it out. Is that damaging the endothelium, the intima? Are you actually causing more damage there or not? Again, we don't have data, but any comments on that, either Omar or Srini?
I mean, there's a few studies out there that talk about that if you cut into the adventitia, that your patency rates are reduced, right? And I think that was, again, shown by, you don't know how much of this, there's no comparison, right? It was shown by a company that sells a directional atherectomy device with image guidance, right? So it was shown by them. There may be some other studies, but they showed that if you do cut into the adventitia, your restenosis rate is higher. So again, we don't have a head-to-head comparison with the other devices. And so, I don't know if I can say anything really more about that. Maybe Omar has something he can talk about.
Don't have too much experience with the directional atherectomy devices. That's just not something we've been doing in our practice. And that's not something because it's a bad device or anything like that. It's just because we are big users of like BARD and Philip products or CSI products. And so that's kind of what we're using. So, don't have much experience or insight into some of the directional atherectomy devices.
Sure. Yeah, I mean, it's always a point of concern, but I think the technology has improved, but we'd have to really kind of have more data about that to know. Again, I don't know of anyone, and you guys can comment on this, who are only doing an atherectomy intervention, not followed by some sort of secondary intervention, whether it's POBA, DCB, or stenting. I mean, no one is just doing atherectomy to your knowledge, correct? It's always followed by some sort of secondary intervention. So, it might not really matter as much. Now, let's talk about technique a little bit. A lot of times, you get through your lesion, whether it's a high-grade stenosis or an occlusion, and do you typically avoid angioplasty prior to doing an atherectomy, or do you want to keep as much potential contact for the atherectomy device? Omar, anything that you do, or do you go atherectomy followed by secondary intervention?
Yeah, I would say 95% of the time I'll probably do atherectomy first. I mean, the only time I think I would not do atherectomy is if the lesion is so tight that I can't even get like a small, I couldn't get the atherectomy device into, through the lesion, right? And that's something like a long SFA occlusion or something like that, where I may go in with like a 2mm balloon or something, just create a little space to kind of make sure everything goes smoothly. But most of the time I will just do atherectomy, or like I would use my algorithms, kind of like get through the lesion, IVUS, atherectomy, then angioplasty, then maybe IVUS again to see what's going on, and then decide if it needs anything else, like, additional balloon angioplasty or stenting, something like that.
Okay. Srini, you too? What about you?
Yeah, I mean, I think that's part of the problem, right? I mean, we all try to follow the IFUs, and I'm sure those are pretty strict in terms of how you're supposed to do things based on their feasibility and safety data. But, in practice, most of us, if we need to do atherectomy or some type of vessel prep, we may have to do an angioplasty, like Omar said, to get the device through, right? If you can't get it through, you don't want it to get stuck. So I think quite a few operators do angioplasty ahead of time, just before they do the atherectomy. But they do, again, low pressure. They usually tend to use smaller balloons than the actual native vessel. I think Omar would agree on that.
Yeah.
You mentioned 2mm. That's what kind of even go
3.
The thought is you want to keep as much contact of the device. I mean, these devices,
right?
You talked about orbital atherectomy being, going in an orbit, so that creates the diameter. But a lot of these other devices, like rotational, it's only the size of the catheter. I mean, you can do like blades up and blades down on some devices, stuff like that. One of the age-old questions people will always ask is, all right, Omar, you talked about getting through like an SFA occlusion, and you can use IVUS to see if you're subintimal, true lumen, etc. What are your thoughts about atherectomy in the subintimal plane?
I avoid atherectomy in the subintimal plane, and that's where IVUS is so helpful for me. But I've heard both, where people avoid the subintimal space or people do atherectomy in the subintimal space. But for me personally, I will use IVUS, and if I see the subintimal plane, I'll probably avoid that, and that'll be reserved for just angioplasty or some type of device like a TAC or the stent, where the true lumen with the disease is where I would just reserve the atherectomy in that area, just because I don't want to have some kind of device complication where it gets stuck or some kind of issue like that. That's my that's kind of my worry when I'm trying to avoid that. So
Srini, same for you, or do you do more in the subintimal?
I think in general, we know that there's a higher rate for pseudoaneurysm formation and perforation. And it kind of defeats the purpose, right? It's off-label, right, for most of all these devices, these atherectomy devices, to use them in the subintimal place. And if you think about it, when you've done a subintimal recanalization, you kind of, what are you prepping at that point? I mean, there are some operators that will say they still laser, they still CSI, et cetera. But I'm not in that camp. I think if I'm subintimal for the most part, predominantly, and I mean predominantly subintimal,
Sure.
then I'll try to avoid atherectomy.
Well, exactly. I was going to say, what about like this, like, in the CKD patient, diabetic, you have this really diseased tibial. There's some subtotal occlusions, some focal occlusions. You get through it. Who knows if some parts are subintimal, or not, but there's a lot of calcium there. Are you IVUSing, Omar, like down to the distal tibial and something like that? Or are you proceeding with like a CSI, knowing that probably some of your wire might be subintimal?
Yeah, I'll try to take IVUS as far down as I can,
Okay.
just to have an idea what's going on. And it also helps me to measure the vessel to see how aggressive I can be with the balloon, after the atherectomy. So for that reason, I would probably I try to use the IVUS as much as possible.
That's great.
Yeah.
Srini, you too?
Yeah, and Sabine, there's some anecdotal data right now that even when you've done a recanalization and you've gone in and out of the true lumen, that if you do use orbital, that you end up just creating one big channel. But the risk is that it can still get stuck. And so I think, that's really for the experienced operator who really understands the device and has, some bailout options, should it get stuck. But in general, I'll IVUS it just like Omar as far as I can to see if, what's going on.
That's great. I mean, all these steps, take time. How do you, Omar, you're saying pre-IVUS, post-atherectomy IVUS, maybe then post-stenting or angioplasty IVUS. Those are all big steps. How much time is that adding to your guys' procedure? And how do you address that situation?
Well, I try not to do that many PAD cases in a day. I will, I know some pretty high level operators will do like 5 or 6. I'll probably stick to 2 or 3. Just because I don't want to have that stress of like, oh my gosh, this is taking forever. Another thing I do, I don't know if who else does that, but I just use one wire. Okay. I'll get down to the foot. I'll put in a Viper wire and I do everything over that Viper wire, like 014 wire. I'll IVUS over it. I'll atherectomy. And it doesn't matter what atherectomy I use. I'll use Rotarex, Phoenix, or CSI over the same Viper wire. So my CSI rep's always probably thinking like, why is he ordering all these Viper wires? But anyways, but yeah, I will do everything over that one wire, and I'll angioplasty. I'll put stents over that wire. So that saves a lot of time because I'm not changing out wires and things like that.
Yeah.
We just have to take really good care of not losing the wire or like kinking the wire. But I think the techs that I have are pretty good, where we take pretty good care of that little flimsy wire. But that saves me a lot of time, where we can do that. And totally. I don't know if that's something you guys do, but that's helped me a lot with the timing.
That's good. That's good. You did mention something really great, is not to put too much into your schedule. That is the challenge that I face at a hospital-based group, where predominantly a lot of my cases are inpatient add-ons, and the hospital administration is forcing us to try to get patients out of the hospital or whatnot. And we're trying to do as much. And that affects, some of the things. So it affects some of my decision-making negatively, where I may not, pull out the IVUS there because I got through, let me angioplasty this, it's fine. And then you come back and say, okay, well, there's no date, there's all these stuff that you can think about and justify, but it's not the right thing. So in your guys' office-based labs and surgical centers, it's kind of nice that you can control that type of schedule. I think it's a lot better procedurally, technically, and everything for the patient. Srini, that's how you're planning on doing stuff? Or?
Yeah, and Sabine, I think that's the argument, the counter argument, right? People always say the same thing. Does IVUS really make a difference? There's no real true study that says it makes a huge difference in outcomes. Does it make a difference in the acute treatment, in the acute result? I think we could say yes. Same thing with atherectomy. People are like, why? It's expensive. You got to use devices. You're adding risk. It takes time, cost, etc. It's the same argument. And so, again, but then there are those that'll say, well, in the acute treatment, it allows me to be successful in my treatment that day. Whereas others will argue, well, it does make a difference. Rutherford class has improved this and that. But again, those are registries, right? No RCTs, no head-to-head comparisons for the most part with large numbers. And so again, I see both camps and I get it, but I think our model, because we're very big, and I'm a big believer, just like Omar, in vessel prep, in plaque composition and modification or removal in some way, whether that's laser, ablative, rotational, orbital, whatever it's going to be, because I do think it allows me to treat and stent less. It allows me to do lower pressure angioplasty and have a lower risk of perforation and dissection. So that's kind of the way I think about it, that, it definitely helps me in that respect. But can I, say that the data says it's the best thing to do in terms of long-term outcomes? I mean, not for the most part, right?
Yeah, no, that's a good point. I mean, we talked about, you talked about these complications like perforation stuff. We talked about embolization. Something I forgot to ask is, I mean, are any of you using embolization EPDs during these interventions, like a Spider or NAV6, or have you gone away from using a embolization protection device? Omar?
So I used to use an embolization protection device when I was using Jetstream for like a long segment occlusion, ISR type case. But I have not had an issue with Rotarex with like a bad distal embolization complication. And I would say I've probably done over like 50 or something, and I haven't had any issues with Rotarex with ISR, treating like ISR or something like that. Obviously, and so I don't use a filter. I feel like sometimes filter can cause complications themselves or things like that. You try to, and it takes a lot of time. So, I mean, I personally don't use filter devices, but I do have techniques. Like if I do see distal emboli, I have some stuff in my lab where I can go and try to aspirate it out or something like that. So that's what I do. That's what I do. So
I think that's one of the benefits. I mean, again, this is not a Rotarex, commercial or anything, but I think that's been a very great addition to the atherectomy market here. Srini, you mentioned you use a lot of laser. When I was doing laser for ISR, I actually had a couple embolizations. And then I started using an EPD. Is that just operator failing, or is that something you do? I don't know the right answer.
No, I mean, again, we all know this. I mean, all these devices have problems of some type in terms of distal embolization. Again, the percentage is small, but it's real and it's there, and it can be catastrophic, as we all know. I think what's made a big difference, and I misspoke previously, but the Rotarex has aspiration ability regardless of the size, I think, right, Omar?
Mm-hmm. Yeah.
Is it all the catheters?
There's like a 6
or is it just a large? I think it's the larger ones, right? There's the larger two sizes, I thought. I can't remember offhand, but we'll have to look that up.
I think there's just two sizes. I think both of them do.
They both do. Okay. So with laser, obviously the Philips laser has no aspiration ability. I have seen distal embo with that, especially with ISR. I'm not so sure it's the laser causing the embo. I think it's you laser and you have that goopy stuff that's in the lumen. You do an angioplasty and it embolizes distally. So people always recommended run it multiple times through there to kind of remove as much of that and vaporize as much as you can. I think with the angiodynamics laser, in that case, the larger catheters have aspiration ability. So that adds another, safety component when you're using it. As far as distal protection devices, I'm kind of in Omar's camp. If they have really poor runoff, I'll start thinking about it. If I have a long segment occlusion or a heavily diseased calcified vessel, I'll think about it as well. There's one paper out of Mount Sinai, New York. I think it was the Prakash Krishna and his group. I think it might have been 1,000+ patients. I can't remember offhand, but they basically came up with an algorithm based on the plaque, how much calcified it was and so forth, of when you should use a distal protection device. So that's an interesting paper that they wrote. But again, this is all anecdotal. We don't really know when to use it. It's an experience thing. Some people never use it and they say they swear by it. Others use it all the time. They swear by it. So I think it's an experience thing that you just have to come up with on your own.
Yep. Absolutely. I mean, yeah, I started using it, but then I stopped using as much laser once, we got Rotarex, but I definitely was using EPDs. They're just because of anecdotal, right? You get some anecdotal cases that go like that, then you change your practice. I'm obviously going to ask the most controversial part of atherectomy, and it's I know you guys you knew it was coming, but a lot of people talk about the financial incentive to do atherectomy and that leading to abuse. And what that means is that, atherectomy reimburses really, really well, whether you're in the hospital or in the office-based labs like you are. How is that, what would you comment about that leading to abuse, and how would you fix that? Or is it just a problem that we have?
Well, look, at the end of the day, you could make the same comment about stenting as well, right? You get paid better for stenting an SFA or an artery than you do for just doing standard angioplasty. So then do we do away with stents? I think there are certain indications and important reasons of when you should place a stent. Again, I think with atherectomy, there's enough data out there in terms of feasibility, safety, that it does make a difference in terms of helping you with an acute result where you may have failed otherwise, using less stents, having less dissections, less perforations, etc., that I think you can make the case that atherectomy is another one of those things that is needed. Can you abuse it? Sure. You can abuse it just like stents. So we don't get rid of stents. So, why should you get rid of atherectomy, right?
That's a great point.
And you're going to have bad apples everywhere, in every field, every specialty, and every career path. And so we've got some bad operators that abuse it, and they make it bad for all of us who try to be a little bit more thoughtful in terms of how we use it as a vessel prep device, right? At least that's my opinion.
No, that's a great point. I mean, Omar, anything else you would add about that?
Yeah, no, not really. I mean, I think I totally agree with Srini. Like, there's going to be bad operators that are going to be just probably, but I mean, I think majority of the people have, good sense and, to do it ethically fashion, because, you're going to have that type of financial people with that type of, motives, right? So, I mean, but that shouldn't allow that shouldn't get rid of, what we're trying to do with atherectomy or stenting and types of interventions on these sick patients. So.
Right. Totally. I mean, I think, like Srini mentioned too, I mean, when we have used atherectomy, we have definitely, seen less dissections, better vessel prep, and better, outcomes from just anecdotal evidence. So, I mean, the bad apples will be there, but as long as, all of us are doing the right thing, it's there to stay. Any other technologies either of you guys know that's kind of out there, upcoming? For atherectomy?
I mean, none that I'm familiar with. And maybe Omar. How about you, Omar?
No, I mean, Shockwave's great, right? I have little experience with it, but I don't use that much. But there's like some other devices that we use that, that might help some of these like really sick patients, like some things that like Serenator balloon comes to mind, where like we have these like tibials with, you do atherectomy, angioplasty, you still get recoil or not good runoff, then so I've had some success with some of these other like, specialty balloons, whether it's like Serenator or it's like some people have talked about chocolate balloon, things like that. So, that's one thing I like to use. The other thing I use a lot is like angioscope balloons, like for ISR, where if the atherectomy or, say you do Rotarex angioplasty, you don't get a good luminal gain in some of these areas that are really tight, then I'll go in there with like an angioscope balloon, go up to like, 20 atmospheres or something like that to kind of get a better result. So that's some of those type of things I use in the OBL. And, you want to keep your costs low, but one of the advantages of it being like my practice, I can kind of do it around, which is nice. But that may not be for every, for all the OBL operators where you have to really kind of look at costs. So, so things like Shockwave, Serenator, these angioscope, these are pretty expensive devices. So, but it's nice to have when you need it. So.
Yeah. I think, Sabine, also, we got to think about it, especially for the trainees out there, that we're really talking about vessel prep, right? Vessel prep before definitive therapy. And that could be a sculpting balloon like the ones that Omar talked about. It can be standard angioplasty, which most of us, I think, don't do as much as we did in the past. And then obviously it can be any one of these atherectomy devices. And even though Shockwave doesn't have an atherectomy indication right now, it does have, it is a vessel prep device, right? It causes microfractures of the calcium in the intima and the media. The idea is that it softens it. So now when you angioplasty at a low pressure, you're pushing it off to the side and, getting luminal gain. So I think, and even that one, although it's not often, that still has some reports of some distal embo. Very rare, but many operators who use it very heavily and are experienced in it do tell me that they have seen a few cases of that as well. So again, I think embolization is a problem with all of them. It's not common, but it does happen. And I think thinking of it as a bigger category of vessel prep with sculpting balloons, atherectomy, and then Shockwave in there is probably a good way to think about it, in terms of big picture for people that are just learning.
That's great. Yeah, big picture. I mean, we did mention in the beginning, what is atherectomy as far as debulking, but we mentioned plaque modification. I mean, I think the whole thing centers around modifying the plaque so that your intervention will cause less complications, or it will, result in less dissections, perforations, etc., and lead to better outcomes. So that's a very good point, Srini and Omar. And yeah, I mean, that concludes kind of the questions I had for you guys for atherectomy. Anything, you gave a really good point there, Srini. Anything, Omar, you want to tell listeners about atherectomy, or anything about, any words of wisdom from your side?
I think atherectomy is great. In the OBL space, you really don't have that much of a backup, right? You want to use it, and there's always those times where you can have a complication. So I guess to the listeners who are in the OBL space, kind of plan accordingly. Don't, if it's like a very tough, challenging case, maybe take that one to the hospital. Or have some devices in your OBL space, such as like aspiration devices or bailouts, covered stents and things like that. So, you're not having to transfer the patient, if something were to happen. So that's kind of, but I think atherectomy is great. And I'm not saying that's just from atherectomy alone. I mean, that could happen when you're doing any type of
Totally.
lower extremity procedure on the patient. So, but I think, with the right, in the right patient, I think atherectomy is a great tool to get the, blood flow to the limbs.
And I think, Sabine, I think in general, everybody always asks, which one should I use? What should I use? How many should I get? And I think, Omar laid it out at the very beginning. Do you have how am I going to deal with soft plaque? How am I going to deal with calcified plaque? How am I going to deal with ISR or the combo thereof? And pick your devices on that. And whatever you choose, become an expert at it. You don't have to have all of them. I mean, look at Omar. He's doing great work. He's got a couple devices. I only use a couple devices too. You only use a couple devices when you do use them. So I think, most people, that's how you have to function.
Awesome. Great words of wisdom, guys.